Welcome back. I hope everyone had a nice lunch and some time to socialize with colleagues. The medical students, residents, and fellows hopefully enjoyed their scheduled lunches. I'm Christine Velasco, and I'm one of your moderators today. I'm the Director of Colorectal Surgery at Arnold Palmer Hospital for Children. My co-moderator is David Darcy, and he is an Assistant Professor of Surgery and Pediatrics at the University of Rochester Medical Center Golisano Children's Hospital. If you are one of the people voting and scoring abstracts, we remind you to please open that and vote for all these great presentations today. This session starts our first scientific session and focuses on colorectal surgery. It is my honor to introduce our first presenter, Dr. Pat Warden from the Naval Medical Center in San Diego.
Good afternoon. My name is Utsav Patwardhan. Thank you for the privilege of the podium. We have no relevant disclosures. Meconium ileus, or MI, is an obstructive gastrointestinal process of newborns that is almost exclusively associated with cystic fibrosis. Thick, inspissated meconium occludes the intestinal lumen, causing obstruction. In severe cases, this can lead to perforation or peritonitis. Non-operative management typically entails administration of a hyperosmolar water-soluble contrast via the rectum, which is successful in about 40% of cases. But when there's persistent obstruction, operative management is often necessary. Historically, partially diverting stomas were constructed, and the distal bowel was irrigated with saline. But in recent years, N-acetylcysteine, or NAC, has proven to be a much more effective agent for operative mobilization of meconium by breaking disulfide bonds. NAC is typically instilled via an enterotomy proximal to the inspissated meconium or through the ileal stump after division of the bowel. Obstructing meconium is then evacuated via the same site or through the appendix, and the enterotomy is then closed, or a diverting stoma can be constructed. We evaluated the efficacy of a less described approach whereby 2 to 4% NAC is injected directly into the inspissated meconium in aliquots of about 0.2 mLs every 15 to 20 millimeters. The mobilized meconium is then pushed into the colon or evacuated via the appendix, allowing for decompression of the dilated proximal bowel. We conducted a retrospective study of infants who were operatively managed for meconium ileus at 6 centers in the US and Australia. Patients were included if they underwent operative intervention for simple or complicated meconium ileus, and NAC was used to facilitate mobilization of the meconium. Patients managed with standard techniques were compared to those in whom NAC was injected with a needle. The primary outcomes were operative time and time to full feeding. Secondary outcomes included time to first stool and the need for subsequent procedures. We hypothesized that needle injection patients would have shorter operative times with comparable outcomes. We identified 52 patients who underwent operative management of their MI with installation of NAC. In 9 of these, needle injection of NAC was used, and the remainder were managed in a standard fashion. Among those patients, meconium was evacuated via the enterotomy or the divided bowel in the majority of cases. On the other hand, most of the infants managed with injection had meconium evacuated into the colon without any enteral contamination. Patients in both groups were demographically similar. However, patients managed with needle injection were of significantly lower gestational age and birth weight. Needle injection patients had a significantly shorter median operative time of 90 minutes compared to 133 minutes with standard management. Rates of bowel resection were equivalent, and very few patients in either group needed a second operation to instill NAC. Other outcomes were largely similar, including time to first stool, time to goal feedings, and length of stay. Similarly, the need for reoperation and 30-day mortality were infrequent. In order to address potential confounding from the 4 patients with complicated meconium ileus, we completed a subset analysis of only simple meconium ileus patients. Our results largely remain the same, with operative time still being significantly shorter in the needle injection group. Length of stay and time to stool were again equivalent, but notably 30-day mortality was higher in the needle group. However, both deaths were due to pulmonary-related complications of cystic fibrosis and not GI-related problems. In a multi-center international retrospective study, 9 of our 52 patients were managed with needle injection of NAC. Patients managed with needle injection were younger and had a lower median birth weight. Meconium was effectively cleared via the appendiceal stump or colon and passed rectally. The avoidance of an enterotomy and more direct installation of NAC likely contributed to the 50% reduction of the operative time, which has significant neurodevelopmental benefits for neonates. Despite the shorter operative time and less invasive approach, outcomes were largely similar. So to conclude, although patients managed with needle injection were younger and had lower birth weight, their outcomes were similar to those managed traditionally. Meconium was effectively cleared via the appendix stump or via the colon and passed rectally, resulting in the shorter op times that I described. For stable patients, needle injection appears to be a less invasive approach to mobilizing meconium. Thank you for your attention. I'd like to acknowledge the efforts of our partner institutions and my mentor, Dr. Gollin.
So, Raj from Australia, good paper. I have two questions. Because from the time of meconium ileus to the diagnosis of cystic fibrosis, it takes time. And the meconium is still going to be formed, which is not good. So one of the reasons why people were originally doing enterostomy is to use N-acetylcysteine continuously until you get the things better. So my question is, how are you going to manage that spirit, putting an NG tube or NJ tube all the way? Second question is, many times I don't know whether I'm dealing with total colonic Hirschsprung or meconium ileus, so I take biopsy anyway. So what's the point if you're going to do biopsies? You might do a quick operation, do an enterotomy, remove it, takes only 15, 20 minutes. What is the big deal doing this?
Yeah, no, this is a great question. So we didn't collect information about whether biopsies were taken, but we did ask one of the questions, I didn't include this for time, how many of these needed NAC to be administered afterwards? So about 40% of these patients needed via the NG tube some sort of administration afterwards, but still that's over half of them didn't need anything moving forward. So we thought that was the benefit of just simple needle injection, small holes, there's no enterotomy to close, and the operative time was a lot shorter. And so I think for simple MI cases where you're looking, the bowel looks viable, there's no complication, I think this is a good way of managing it.
I thought simple cases we do radiology.
Well, no, this is simple that still required operative intervention.
Okay.
Yusuf Gohari from University of Missouri. Quick question. What's the needle gauge?
So the needle gauge, we use a 20, so we didn't stipulate it for all of our centers. We suggested a 25 using a tuberculin syringe, but it wasn't always standardized across our centers. So that's something I think as it gets studied more, you can sort of standardize this procedure. One of the things that, in a similar note, is what concentration to use. I think a lot of people deviated from that. It wasn't always reported in the op note very well, recorded the exact volume, and so that's something that would need to be done prospectively in the study, standardizing all of these things. Okay, thank you very much.
Great job there. Next up, we have Dr. Ulrich, who's the colorectal surgery fellow at Cincinnati Children's Hospital. And she's going to be talking to us today about surgical management of very early onset inflammatory bowel disease.
Okay, good afternoon. Thanks for the opportunity to present our work today. So it's estimated that up to 25% of inflammatory bowel disease cases are diagnosed in childhood, and about 1 in every 7 of pediatric IBD cases are diagnosed in children that are less than 6 years old. These are considered very early onset, or VEO. Though the overall incidence of pediatric inflammatory bowel disease in North America has been relatively stable, the incidence of inflammatory bowel disease in the VEO population has been increasing relatively rapidly at a rate of about 7% per year. There are some ways that VEO IBD is phenotypically distinct from IBD in older children. It's more aggressive, colonic involvement is common, patients are less likely to respond to induction medical therapy, and are more likely to have a monogenic etiology, usually from inborn errors of immunity. Surgical intervention for VEO IBD has not been the focus of previous studies, and its role in treating this patient population is unclear. So we sought to better understand which VEO IBD patients are most likely to need surgery and what operations we're performing for them. So to do this, we performed a single-center retrospective review of all VEO IBD patients treated at our institution from January 2008 to May 2024. We reviewed patient demographics, we assessed disease severity using the Pediatric Crohn's Disease Severity Index, and we recorded which medical therapies and surgical interventions these patients received. So 121 patients met criteria for inclusion. 63% had disease localized to the colon, and 31% had ileocolic disease. 11% of patients were diagnosed at less than a year old, and half of the patients were referred to us after treatment from another facility. So 22% of patients had surgery, 69% were diverted with an ileostomy, 35% had a bowel resection of some sort, 6 of these patients had a colectomy, 2 had an ileocolic resection, and then 1 patient had a previous ileorectal anastomosis for colonic atresia, developed disease there, and then we did a resection for that. And then 27% of patients had an anorectal EUA with or without aceton. These were not mutually exclusive criteria, which is why the percentages add up to more than 100. So we examined a number of different demographic factors. The only statistically significant finding was that Black patients were more likely to need surgical intervention. And this held true on multivariate regression, even when adjusting for distance traveled, opportunity grade, which is a composite measure of socioeconomic opportunity at the county level, and insurance status. Black race remained a significant predictor of the need for surgical intervention. So additionally, we found that patients who were diagnosed at younger than 1 year old were more likely to require surgery. Patients with mild or moderate disease, as measured by the Pediatric Crohn's Disease Activity Index, were more likely to need surgery. And then when we broke down the components of that severity score, we found that the number of stools per day was a significant predictor of the need for surgery. Additionally, we found that patients who had linear growth failure, as defined by their height for age Z-score at presentation, were more likely to need surgery. We also assessed the initial medical treatment prescribed and found that patients who were initially treated with immunomodulators were more likely to need surgery, and that these disease level factors remain significant predictors of surgical intervention on multivariate regression. Patients who had more than 8 stools per day had a 46 times greater odds of having surgery. And then on a continuation of the same regression model, we found that patients with a height for age Z-score that was more than 2 standard deviations below the mean had a 22 times greater odds of requiring surgery, and patients initially prescribed immunomodulators had a 30 times greater odds of requiring surgery. We did assess if patients had a change in linear growth velocity at different time points before, during, and then after an operation, and we did not find a statistically significant change over time. And then similarly, we assessed that if there were changes in different medication uses at different time points. We found a trend towards a decrease in mesalamine and immunomodulator use after surgery, but those were not statistically significant. In summary, we found that the need for surgical intervention in VEO-IBD patients is associated with Black race, diagnosis at age younger than 1 year, linear growth failure, and disease severity. It's not associated with changes in linear growth or medication use over time. And this study does have some key limitations that are worth noting. The data is retrospective. Half of the patients that were included in the study were referred after treatment from other centers, which introduces bias. I didn't present that result here, but that was not a predictor of need for surgery. And then we also had a relatively small sample size with inconsistent follow-up, and that increases the risk of a type 2 error, especially for those longitudinal models. However, this is the largest single-center review of surgical intervention for VEO-IBD, and I think it opens up the door for multi-institutional prospective studies in the future. Thanks again for the opportunity to be here today, especially to Dr. Rosen and Dr. Fisher and the colorectal team at Cincinnati Children's for all the support over the years. Happy to take questions.
Hi, I'm Jim Pierce, Central California. So I was wondering, since many of them are associated with a genetic finding, do you think, skew your race? We have a Hmong population in our area with a CGD, and I've seen a couple now. And then the second question was, the thing that forced my hand to operate on several of them was they got secondary infection. And so C. diff would jump on top of it, and then you'd end up with this gangrenous colon. And I wonder if you looked at any of the infections.
Those are great questions. So I did look at the monogenic etiology. That was not an independent predictor of the need for surgery. It was really age, even when I tried to adjust for those 2 variables together. because the children that were diagnosed at an age less than 1 year old were definitely more likely to have a monogenic etiology. We did not look at secondary infections. I think that's a great point because taking care of those patients, that is something that does come up, especially for the ones that end up getting their colon out.
Hey, Tony DeRoss from Cleveland Clinic. Just a couple questions. Follow up on that. What were the indications for surgery in most cases? Was it obstruction? Was it refractory disease? Second, was age and an insurance availability a factor for getting certain therapies that might not be available to kids that young through insurance? And also, what is your standard management for patients with VEO-IBD in terms of colonic disease? I think ileocolic disease is a little easier to manage because you can do a resection, it's not a big deal. But if you do a colectomy, then these kids, they get a J pouch and they end up having Crohn's or something later. What's your standard management just in general?
Okay, I might need you to repeat some of those. So the first question was, what was the indication for surgery? And so usually it was hard to kind of tease out because a lot of times it's multifactorial. It's either the kids are bleeding, they're having growth failure. So I didn't necessarily tease that out, but I think that is something that's worth looking at, especially as we build prospective studies, because that's something that was hard for us to answer. Like, when do you operate? I think in pediatric IBD, and especially in this population, making the decision to operate is hard, and especially like deciding to take a colon out on a 2-year-old, that's a big life-changing decision. The second question.
Insurance
Insurance.
Availability of certain medications.
Yeah, so I looked at insurance status as an independent predictor for the need for surgery. That did not come up as an independent predictor. And then we also looked at the opportunity grade, which is kind of a composite at the county level to see like if you can account for other socioeconomic factors. And that was also not an independent predictor of the need for surgery. I think the choice of medical therapy for these patients is a hard thing for our GI doctors because there's no biologics that are approved for use in kids that are less than 6. And so some people are hesitant to prescribe those. And so that's why I think we saw a lot of kids on immunomodulators initially. Within an older kid, they would be started on Remicade or something. I think that's also something worth noting because those kids might be less likely to need surgery if our induction therapy was different. And then there's one more.
Just about how do you guys manage colonic disease, isolated colonic disease?
I think we try to surgically manage. We try to divert when we can to save the kid's colon, and that's been our practice for all pediatric IBDs if it's possible.
I'm from Australia, so I'm just gobsmacked by the number of cases you're operating. The last 5 years, probably because mine is an Anglo-Saxon population, probably of Scottish and Irish descent and all that. Mm-hmm. But the last 5 years, we rarely operate on Crohn's disease. First 15 years, all of us learned our colorectal surgery on Crohn's disease. Just wondering, is it because the new medications completely taken away from the surgeons to the hands of physicians? And have you looked at the data on the last 5 years compared to the 15 years? Because the new drugs are far superior to surgery.
Yeah, I think that's a great question. So have the rates of surgical intervention changed over time? I think that would be complicated for us to answer because we saw a lot more patients over the last 15 years as our referral base has broadened. So we saw when I tried to sort that out, the N of patients was so much higher, I broke it up into 5-year intervals. And
yeah, and so that you don't have a denominator. Because
right.
in a hospital like mine, we have a denominator.
Right.
You know that the incidence have doubled, but the actual surgery has actually
But your
come
patient
down.
population has stayed the same. And I think, overall IBD is becoming just a much more centralized, people are trying to centralize care a little more for that. So, right.
Great
Thank
job.
you.
Thanks very much.
Dr. Fisher, we're going to need a bigger room next year. We've got standing room only. So just take note. All right. So I'd like to welcome our next presenter, Dr. Melkonian from the International Center for Colorectal and Urogenital Care at Children's Hospital of Colorado, and we'll be discussing pediatric surgical care of anal rectal malformations, a global survey.
Thank you very much. So this is a project from last year when I was a colorectal fellow at Colorado. So this is our short list of participating international surgeon authors, and we have nothing to disclose. So why we did this research? So we were inspired by the goal that every child with anal rectal malformations deserves high quality health care regardless of where they are born in the world. And so children with anorectal malformations face long-term implications based on their care. And our study evaluates perioperative disparities both in diagnostics and surgical planning. And the results can help in guiding quality improvement initiatives and aim to reducing surgical disparities with children with anorectal malformations. So this includes appropriate neonatal screening, perioperative management, and long-term follow-up. Our objective was to examine the management of anorectal malformations by pediatric surgeons worldwide and assess areas of consensus and variability in regards to perioperative care, also reporting outcomes. So a survey was sent out through the Hendren Project, which is a global network community of pediatric surgeons and urologists on March 15th, 2024. And surgeons could participate by retrospectively reviewing the last 10 patients that they operated on for anorectal malformations at their institution. And only primary cases and no reoperations were included. And the data was analyzed both at a patient level and at a hospital level. And the hospital level was further broken down into 5 continents, so Africa, Asia, North America, South America, and Europe. And we subdivided into the World Bank income level, where we put low and low middle together, as well as upper middle and high income. And for our results, we had 900 patients reported with anorectal malformations, 90 different hospitals, 144 different surgeons, and over 50 countries. And one of the first things that we found was sacral x-rays, which are recognized as a key prognostic tool for bowel management in the future in these patients with anorectal malformation, were not being done routinely on all patients, where only 78% of patients had a AP view and only 65% of patients had a lateral view, even though this study, plain films are basically universally accessible. And then furthermore, looking at spinal imaging, so only 50.2% of patients actually had spinal imaging screening, and only 80% had an echocardiogram, remembering that with anorectal malformations, cardiac anomalies can happen up to 30% of the time, and spinal issues can happen up to 25% of the time, so this was significant to us. When stratifying newborn screening by continent, the only statistically significant difference that we saw was actually with spinal imaging and screening. And the high-income countries were performing it almost 100% of the time, while it was much less utilized in the lower-income countries. And while MRI is not universally available in the lower-income countries, ultrasound should be fairly ubiquitous. And I did a quick literature search to see how available it is at most low-income countries, and it is available in most institutions. Then looking further at how the colostomies were being formed, so 66% of the colostomies were divided colostomies and 28% were loop colostomies. Traditional teaching has been that divided colostomies would reduce the amount of UTIs, but recent research has come out to suggest that regardless, it doesn't matter which one you use, although it's still hotly debated. And then our complications, overall complication rate was 27.2%, with the most common being dehiscence at 11.7%, and followed by wound infection and stricture at 7%. We also looked at the time of definitive surgical repair. So 30.6% of patients were getting their repairs after 1 year of age, and 62% of patients were getting it after 6 months of age. And so this was important to us since there's been a lot of literature out there suggesting that the earlier repair may help with development of the defecation reflexes, as well as reducing the number of surgeries if a colostomy hasn't been performed. And looking further, in high-income countries, it was statistically significant that less colostomies were being created before anorectal malformation surgery, before the reconstruction surgery. And this might be because the NPO time and the availability of TPN. So limitations, this was a retrospective review. So it introduces the possibility of recall bias. We had a lack of standardized collection across the institutions, and that may lead to variability in the reporting. And also we had the lack of information explaining why screening practices were incomplete and why repair was delayed beyond 1 year of life. So in the future, it would be nice to include more questions, including the rationale for omitting recommended pre-op screening, perioperative antibiotic use, the use of preoperative bowel preparation, the length of NPO time after PSARP. But now these future studies we can formulate with a similar type of approach that we did with this survey. And then the takeaway points, so sacral radiographs, crucial for prognosis, were inconsistently done. Surgical care disparities for these anorectal malformations do persist and delay in repair, and incomplete screening and identifying these factors would be crucial for improvement initiatives. I just want to say thank you to Dr. Pena Bischoff and Dr. De La Torre for the great year last year.
It was a really great review and survey that obviously took a lot of time and effort to put together. I think in your abstract you had mentioned how so many of these kids did get their renal ultrasound, but then the spinal screening was missed. So it
Right.
seems like a real teachable moment
Yeah.
to get that information out there.
Hi, Richard Wood from Columbus. Thanks very much for a great talk. I had two comments. The one is, it's probably worth asking the people in lower income countries who are not doing spinal ultrasound if they have neurosurgeons to do tethered cord releases, because in a lot of places that I've been in Africa, if you don't have a neurosurgeon to do a release, there's not much point doing an ultrasound.
Fair.
And then I think as there's questions about the sort of validity of sacral ratio, I probably think that's maybe much more controversial outside of the US. It's
Okay.
not really widely accepted outside the US, and it's even questionable here. So that may be why you're seeing that.
Yeah.
Thanks, Rich. I'm just going to add one thing. The diagnosis of the tetrachord can also help for a more urological screening. So I think even if you don't have a neurosurgeon, it's still worth getting the diagnosis.
Very nice. Dr. Melkonian is going to stay up on stage here. In conjunction with Children's Mercy Hospital, he has another abstract to present. This is failure to launch pediatric colorectal surgery center utilization by patients over 18 years of age.
All right, thank you. So no disclosures. So many patients with childhood onset colorectal diseases continue to depend on their pediatric hospitals for care coordination well into adulthood. And the question came up, is there existing data that quantifies what this resource burden is? And despite looking pretty deeply into this, I didn't find anything that really quantifies this resource burden. And it's important because it would validate the need for further transition programs, present data that can support these institutional investments, highlight ways to reduce the burden on the pediatric centers so that we can focus on the pediatric patients they're intended for. And it could also enhance long-term outcomes for patients into adulthood. So children with childhood onset colorectal disease require lifelong multidisciplinary care. And a critical component of ensuring their optimal long-term care is their successful transition from the pediatric systems to the adult healthcare systems. So our purpose was to evaluate how patients aged 18 and older who have not transitioned to adult care continue to use our pediatric colorectal center, and to assess the extent and impact of this resource use. So we did a retrospective review from August 2017 to March 2024. We looked at every patient who continued follow-up actively after their 18th birthday, and even those who had successfully transitioned out into an adult center after their 18th birthday. And we excluded anybody who had less than 12 months of follow-up after they turned 18, and those who established care with our center after they had turned 18. In our results, we found 116 patients older than 18 that were still following with us, and we found a median follow-up of 30 months. And 80 of these patients, or 69% of these patients, remained in pediatric care. This is just a quick demographic slide. And then looking at our transition to adult care, it varied by diagnosis. The diagnoses that were statistically significant is neurogenic bowel and inflammatory bowel disease had the lowest transition success rate. The rest were not statistically significant. And looking at the total utilization, and kind of the crux of this entire project is over those 30 months with those 80 patients, there was 180 ER visits, 243 hospital admissions, 1,400 clinic visits, 18,000 phone calls and messages, and 1,100 radiologic studies. And breaking it down further just by which specialties we're seeing the most utilization, ER room visits, colorectal was obviously seeing the majority of these. And it holds true for hospital admissions, for clinic visits by specialty, although urology you'll watch will slowly start to catch up, operating room procedures, and phone calls and messages by specialty. And just to break down this, I did just to try to show what each patient would impact the hospital system if they were to stay in care. So on average, there'd be 2 ER visits, 3 hospital admissions, 2 operating room procedures, 19 clinic visits, 236 phone call messages, and 19 radiologic studies per year. So what is the answer? So when looking through, there's a lot of good paperwork or literature out there as to how to have successful healthcare transition, and it discusses beginning with a structured program really early. Some people suggest even as early as 12 years of age, assigning dedicated transition coordinators, identifying an adult provider that the patient will transition to, holding joint handoff meetings between the pediatric and adult teams, establishing adult transition clinics for complex patients, and then using data to help advocate for more institutional buy-in and resources. The limitations, this was a retrospective review. It was a single center, and the colorectal center here at Children's Mercy, Kansas City, was established in 2018. So that is as far back as our data goes with having follow-up. So further follow-up would help to clarify trends in both patient transitions that do become successful, but also in some recidivism if patients were to come back into our system. And so in the future, we could repeat this with longer follow-up. We could include patient-reported outcomes of quality of life measures and identify specific targets for program development and improvement. So takeaway points, so adult patients continue to rely heavily on these pediatric colorectal centers, and it places a significant strain on pediatric resources, and addressing these transition challenges is essential for adult outcomes, but also for the pediatric system efficiency. And thank you to Dr. Rente and Dr. Limbutel for helping me with this project and the mentorship through Colorectal this year.
Andrea Bishop, Children's Hospital, Colorado. Congratulations, Vachi. I think this is an extremely important topic. My only question is, why did you put inflammatory bowel disease in the same group? Because I understand anorectal malformation in Hirschsprung, the adult colorectal surgeon, is unfamiliar. But the inflammatory bowel disease should not be on the same category. So why do you think these patients in your institution are having trouble transitioning?
So good question. So I think the fact that inflammatory bowel disease is not usually involved is because it has not previously been identified as an area needing more buy-in by pediatric surgeons. Part of the reason why I think, I've chosen the path to go to adult colorectal surgery is to help bring back more of this treatment, because I think that a lot of comprehensive colorectal centers don't actually address the pediatrics IBD as much as they should. And in talking to a lot of the adult world, many of them are like, help. We need more help, because these patients come in with multitude of different operations, different workup, and it's not as well, I think, established in many centers. There are some centers that do this very well, but I would say that it's not ubiquitous throughout. So I think that I included them because it is a group that should be included in the future of all comprehensive colorectal centers.
Tony DeRoss, Cleveland Clinic. Yeah, we're a hospital, children's hospital within an adult hospital, so our transition for IBD, very easy. But for patients with pediatric colorectal problems, Hirschsprungs, anorectal malformations, and a lot of times neurogenic bowel, even though we have a spina bifida clinic, no one will take care in the adult world, will take care of patients with appendicostomies, cecostomies, and your takeaways for how we improve this problem didn't list like trying to get finding adult providers who will take care of these patients. Transitioning is one thing, but you need somebody to transition them to.
Right.
So who are you guys sending those patients to?
Yeah, no, it's a great question. And I think, I think it's an answer that has not been found yet. I think that what I have found is that the people I've talked to who have tried to build better transition of care, they meet a lot of roadblocks and a lot of things that don't work because it's not surgical, it's not revenue generating. In my personal opinion, I think the best thing would be is if we could build a bunch of sleeper units where you get a bunch of GI doctors who actually like this, and you train them up and you get them to be subspecialized in congenital colorectal, and they become the quarterbacks. But I think that's tough because I do think it's a surgeon's job, so I go back and forth quite often in it. So,
Just one more question, please.
Hi, Scott Short, University of Utah. We face pretty similar problems, particularly with our IBD kids. And my observational bias is that we can prepare the families and they can elect to go, and we can identify a surgeon who's willing to take on that mantle, their next step in care. But really where we're falling down is on our GI side. So we'll have kids who, quote, transition out, and then they come back a year later with a problem, and they haven't had the Remicade for 6 months, and they can't get into their GI providers. They say the wait list is 6 to 9 months, and maybe their insurance problem. Have you guys looked at that piece or tried to build on that? And if so, are there any recommendations you can provide to kind of help with that?
So we didn't specifically look into that, but there's a really good paper out that was from the GI realm, not from the surgery realm, that discusses how basically it just states how uncomfortable adult GI providers are with managing young adolescent IBD patients. So it's both in the medical realm and the surgical realm. It needs a lot of attention. But I think it's a very hard question to answer. And I think that's what we'll work towards over the next couple of years, trying to answer that question. Thank you.
Great.
Our next presenter will be Dr. Etzkovich from Boston Children's Hospital and discussing intestinal failure outcomes in children with small intestinal Hirschsprung's disease matched analysis.
Thank you. Good afternoon, everyone. Thank you for the opportunity to present this work. I have nothing to disclose. Intestinal rehabilitation in patients with small intestinal Hirschsprung disease is particularly challenging, and little is known about the unique patient factors that contribute to enteral autonomy achievement in this particular population. Our work elucidates some of these factors, which may guide disease-specific rehabilitation strategies in the future. Patients with small intestinal Hirschsprung disease often develop intestinal failure, which can lead to parenteral nutrition dependence, intestinal failure-associated liver disease, and bloodstream infections. While most patients with intestinal failure do not have it secondary to small intestinal Hirschsprung disease, it has been shown that the residual length of their small bowel is a significant predictor in their ability to obtain enteral autonomy. However, we recently found that for patients with intestinal failure specifically secondary to small intestinal Hirschsprung disease, this was not the most significant predictor of their ability to achieve enteral autonomy. Therefore, the objective of this study was to evaluate the influence of factors other than bowel length on enteral autonomy in this population while controlling for various confounders. We performed a single-center retrospective cohort study of patients in an intestinal rehabilitation program. We matched 25 patients with intestinal failure secondary to small intestinal Hirschsprung disease to 50 patients with intestinal failure of other clinically relevant etiologies. The Aspen definition of intestinal failure was used, which dictates a parenteral nutrition requirement of at least 64 of 70 consecutive days. Patients were then matched on small bowel length and duration of rehabilitation, which was based on patient age to account for the influence of age on long-term intestinal rehabilitation outcomes. A comprehensive chart review was then performed to evaluate short and long-term outcomes in these patients. Gestational age was the only statistically significant demographic difference between groups. This finding is consistent with the higher rate of prematurity seen within necrotizing enterocolitis population, which was the etiology of intestinal failure for a large proportion of our control group. Median small bowel length for the entire cohort was 63 centimeters, and median duration of follow-up was 6.7 years. 96% of patients with small intestinal Hirschsprung disease had a stoma at most recent follow-up visit, compared to 6% of controls, and most of these ostomies were noted to be jejunal. Patients with Hirschsprung disease required parenteral nutrition for over double the duration of controls, with 68% of Hirschsprung patients having continued PN dependence at most recent follow-up visit. To understand the impact of small bowel length on these outcomes, we subdivided our cohort into patients who had greater than or less than 50% of their small bowel remaining. 88% of each group had less than 50% small bowel, and 12% of each group had greater than 50% of their small bowel. When comparing patients with less than 50% of their small bowel length, patients with small intestinal Hirschsprung disease required parenteral nutrition for a significantly longer duration than controls. When comparing patients with greater than 50% of their small bowel length, there was a large difference in the median PN duration, though it did not reach statistical significance. This table shows percent of enteral autonomy noted between groups at most recent follow-up visit, and it's divided into quartiles on the left. Patients with Hirschsprung disease were less likely to achieve enteral autonomy regardless of their bowel length. Again, in blue, when comparing the patients with less than 50% of their small bowel length, most patients with Hirschsprung disease received less than 25% of their calories enterally, compared to controls, who were able to receive greater than 75% of their calories enterally. When comparing patients with greater than 50% of their small bowel length, we see a similar trend, though again, this did not reach statistical significance. Small intestinal Hirschsprung disease patients had a significantly higher rate of CLABSI, and no difference was found between groups in anthropometric data or incidence of Eifeld. We do recognize that our results must be considered with the inherent limitations of a retrospective study and the inability to accurately measure certain confounders like dysmotility and chronic inflammatory states between groups. Despite these limitations, we can conclude that patients with intestinal failure specifically secondary to small intestinal Hirschsprung disease are less likely to wean from PN than their peers, and that prognosis is particularly poor for patients with less than 50% of their remaining small bowel. Hopefully, understanding these contributing factors will allow us to guide disease-specific rehabilitation efforts and improve outcomes in this population in the future. I would like to thank my co-fellows for their help with this project and my mentors for their guidance and supervision. I'm happy to take any questions.
Andrea Bishop, Children's Hospital, Colorado. I have a question. Do the patients with total intestinal Hirschsprung, did they still have the aganglionic bowel left?
Yes, that's a great question. So at our institution, we do not remove the piece of aganglionic bowel at this time. However, after looking at the contributing factors for small intestinal Hirschsprung disease patients, we are discussing if this can be a nidus of chronic inflammation. So we know that this piece of bowel, especially in patients where you have a significant amount of your bowel still remaining, can have Hirschsprung-associated enterocolitis and can still have diversion colitis. So it's possible that these systemic insults can affect these patients' ability to rehab. And I know that some centers do routinely resect that portion at the time of leveling ostomy creation. However, at our institution, it's not a practice that we currently use.
So just to clarify, not routinely. So we have the data in terms of how many of them eventually do need resection, and a large portion do, but it's not like a planned, we go back at this point to remove it. And I think there's been a lot of debate about whether saving that bowel maintains domain and blah, 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 but I think the reality is if it's causing trouble and they're not weaning from their PN the way their peers are, that bowel is probably a nidus of inflammation and needs to come up.
Thank you for your question.
Hey, fascinating study. One of the things that I've paid attention to in my career is my evolution of thinking about Hirschsprung's, from it's a motility disorder and we take out the bad part, to, well, wait a second, there are significant immune dysfunctions in the gut in Hirschsprung's, and the part that comes out and the part that stays in. And there's dysmotility for everything else that stays in. So the softball question is, why do you think you are seeing the results that you're seeing? Where do you think the mechanism is?
Thank you for your question. In the basic science portion of our lab, we're actually currently researching potential dysregulation in the intestinal barrier in mice with EDNRB knockouts for Hirschsprung disease, and we're looking at if that has an effect, but I think you're exactly right that more needs to be known about the etiology of this aganglionic and ganglionic bowel, because even the ganglionic bowel that remains is not normal. So I think a lot more work needs to be done to kind of evaluate that. Thank you.
Thank you, very interesting. I may have missed it, but when you for your control group, did you do sub-analysis of how much functioning colon was left in your control groups, and then, if that influenced or not the comparison?
I don't have the exact number. I can tell you that I didn't include this here, but the majority of the control group did have a functioning terminal ileum, a functioning IC valve, and a functioning colon in continuity. So as a huge pillar of intestinal failure literature, those anatomic considerations are very important in achieving enteral autonomy. 0 of our patients in the small intestinal Hirschsprung disease had those. So it was difficult to do a statistically sound analysis compared to 0%, but it'll be something that we kind of talk a little bit more about when we publish the manuscript. And discuss how we can potentially get around those really challenging anatomic considerations for this population. Thank you.
Thank you.
Thanks very much.
Thank you.
So Dr. Kim, joining us from Boston Children's Hospital as well, is going to be talking about contrast-enhanced colonosonography, how it is safe, sensitive, and versatile for evaluation of anorectal malformations.
Hello. Such an honor to be here. Thank you so much for the program committee. We have no disclosures. So contrast-enhanced colosonography is a validated alternative to distal colostogram for preoperative evaluation of anorectal malformations. We sought to evaluate the accuracy and versatility of its expanded use. CECS is highly accurate in characterizing the anatomy of ARM without the use of ionizing radiation, allows for use in multiple clinical settings, and can be safely performed in the newborn period. Accurate anatomic characterization of ARM is critical for preoperative planning. Of specific importance are accurate identification of 1, the location of the rectum relative to the tip of the coccyx, 2, the fistulous communication in the genitourinary tract, and also the length of the bowel distal to the mucous fistula. Our prior work had first identified, then validated the use of contrast-enhanced colosonography as a safe and effective alternative to distal colostogram. So in this study, we further evaluate the accuracy and versatility of CECS in preoperative characterization of ARM by expanding on our prior work with a larger cohort, and hypothesize that contrast-enhanced colosonography offers an advantage because of 1, the timing, because it could be done early on in the newborn period, 2, the broad applicability across clinical settings. So for example, it could be done bedside during an inpatient admission or intraoperatively, and 3, the ability to perform concurrent bacterial screening. This is a single-center retrospective case series for patients who underwent evaluation of ARM at our institution from 2016 to 2025, and patients with cloacal malformations were excluded. Contrast-enhanced ultrasound was performed with the Logic 9 ultrasound machine, and we use a Lumison contrast agent. Sorry about that, advanced too quick. Lumison contrast agent mixed with normal saline, and that was instilled into the mucous fistula with the Foley catheter via a gravity drip. The anterior sagittal, transperineal, and posterior sagittal views are used to image the relationship of the rectum and the urinary tract. And the outcome of interest was the concordance between the anatomy on ultrasound, so the fistula location and the position of the rectum, and compared to our intraoperative findings during final reconstruction. So we would have a patient come in with ARM. We would do a lap creation of a colostomy with mucous fistula, and then we would perform the CECS right at bedside in the NICU for operative planning. So here's a still image example of a bedside CECS with concurrent VCUG. On screen left, we have our conventional ultrasound, and on screen right is the CECS image with Lumisol, which is our dye in yellow. In the gray scale, we can first identify the spine at the bottom with the coccyx that's labeled, and you can see the same in the CECS image. And above, we have the bladder, which is full from the VCUG, and the rectum underneath. And I think you can even see the rectum better in our CECS image. So if this was a live image, you would be slowly instilling the rectum via gravity drip with our contrast, and you'd be able to identify the fistula that develops. So in this study, we can see that 1, our patient has a bulbar fistula, and 2, see that the rectum extends below the level of the coccyx, which dictates our operative approach to go from below. Our study cohort included 50 patients, 46 males and 4 females. Contrast-enhanced colosonography alone accurately guided surgical approach in all of our patients. CECS identified a wide range of fistulas of our interest, and it was also reliable in the setting of no fistula. CECS was mostly performed in the outpatient setting, but also was done during the inpatient admission, and 7 of these were in the immediate newborn period and also intraoperatively. The mean age at CECS was 112 days in our cohort, but it was also successfully performed in the immediate newborn period with the mean age of just 3 days. And concurrent bacterial workup using ultrasonography was able to be performed with ease. So in conclusion, contrast-enhanced colosonography is a validated alternative to distal colostogram that accurately identifies and characterizes the presence or absence of our fistula while also avoiding ionizing radiation. It offers an advantage because of its portability, because it can be used in a variety of settings, because it allows for concurrent bacterial screening, and CECS is instilled via a gravity drip, and it does not need that high-pressure system of distal colostogram, so it's safe and gentle for use in the immediate newborn period. This allows for early and comprehensive family discussion and operative planning. Thank you so much to the program committee for this opportunity. Thank you to Dr. Dickey and Nandivada for your guidance. I'd be happy to take any questions. Thank you.
Nice study.
Thank you.
Who actually performs the ultrasound? Is it a tech, surgeon, radiologist?
Yeah, so we have usually the colorectal surgeon and our radiologist present at bedside, but also the ultrasound tech. So I think at our institution, there's kind of both the radiologists and surgeons very invested in this.
Do you think it's generalizable to all institutions?
That would be the next thing that if I were to try to plan, I'd like to see a multi-center study and see if our findings are generalizable outside of our immediate personnel. Thank you.
Raj from Australia, brilliant study.
Oh, thank you.
Did it help you to do a primary surgery without colostomy? Because most of the people in the third world are moving to primary surgery. They don't do colostomy anymore.
Oh.
And I thought this may be the way to go in future, where you can identify the fistula and do a primary surgery. Your boss can answer.
Yeah. I'm looking over already.
Yeah, I think, to be honest, I think a lot of us worry about the safety of really early surgery, but I hear you and I know this is becoming more popular around the world. And in a way, it's probably safer to do that reconstruction in the newborn period if you're able to perform this concurrently. And speaking to some of our international colleagues, the radiologists across the world are actually very facile in ultrasound in terms of your generalizability question. And so some of the other things we use this for cloaca too, and functional MRI and 3D MRI reconstructions are really quite hard to do worldwide versus an ultrasound exam. So I actually think in some scenarios it's more generalizable, but it would probably at least guide your intra-op decision-making more accurately than not knowing where the fistula is at all.
I wish I had. My first patient is 16 years. I think Penya came to Delhi and he told me, go ahead, Raj, go have a go. And I did it in Australia. I told the patient, I've never done it. Do you want to get it done? And I met Penya in Delhi and he showed me, you can do it. He said, you have to be careful, you have to give TPN and all that. No, we don't do, but my first patient is 16 years and she's perfectly continent in spite of me.
Congratulations on your work.
Thank you.
My question is, you mentioned that you can see how much bowel you have available. Do you do reconstruction? Because it's very important to know if the colostomy was done in the correct spot. And I would say for you to know exactly where the rectum lands, you need pressure. So you need to inject more contrast so you see exactly where the bowel stands. So how do you show the length? Do you reconstruct the images? How does it work?
I know that the length has been accurately seen, but I honestly don't know the exact details.
It's really just a live pan, so it's not a reconstruction. It's just like if you watch the video on any other ultrasound exam, you can get a sense of it. But I think that's why you need to be there as the surgeon. This is not the study you can ask a radiologist to do for an exam that you really need the information and not be there for it because they won't push it to the limit you need.
There was the second half of her point is, for years and years, the most common anal rectal malformation was high imperforate anus without fistula. No, without question, was the most common malformation because they ran in gravity drip and it never opened up the levator and they didn't see the fistulas. So in the history of this with Dr. Pena cutting in the back and opening up and it actually does connect. Look, it connects here, it connects there, it connects there. So, and when you do the distal colostogram under pressure and you're pushing, you see it stop at the PC line. And then you keep going, and then it opens up and all is revealed. So, and that's reproducible, and this sounds like it doesn't need it. So that's fascinating, but can you speak to that? Tell me about how that goes.
quickly, please, then we have to move on.
I think there's something about the air in it. I don't know, but I can tell you it's not pure gravity drip because surgeons are impatient, so half the time Belinda and I are squeezing the bag, but it's not as much pressure otherwise. But maybe it's something about the bubbles. I don't know, but you get really nice distension. So
Nice job.
Thank you.
Next, we have Dr. Reed from Nationwide Children's Hospital discussing safety and utility of long-acting steroid injection for management of postoperative stricture in patients with anal rectal malformation and Hirschsprung's disease.
Hi, thank you all so much for the opportunity to present today. We have no disclosures. For patients with anorectal malformations and Hirschsprung disease, postoperative strictures are one of the most common indications for reoperation, increasing the risk for further complications such as sphincter damage and incontinence. Even short strictures often require multiple interventions to achieve stricture resolution. Therefore, improving the efficacy of our stricture management is key to reducing these risks of reintervention and further morbidity. Intralesional steroid injections are now a well-established adjunct to the endoscopic dilation of intraluminal strictures in various areas in the GI tract, including the esophagus, small bowel, and colon. However, our study is the first to examine the utility of post-dilation steroid injections in patients with anorectal malformations and Hirschsprung disease. These steroid injections are thought to work by inhibiting the local inflammatory response caused by the trauma from the stricture dilation, reducing collagen formation and scar tissue development, and thereby reducing the likelihood of stricture recurrence. Kenalog is the most frequently used of these compounds. Compared to other injectable steroids, Kenalog has a prolonged activity at the site of injection and is effective over the course of about 3 to 4 weeks. Given the success of intralesional steroid injections and other postoperative strictures, the objective of our study was to examine the outcomes for children who have had surgery for postoperative strictures with anorectal malformations and Hirschsprung disease. We performed a single institution retrospective review of patients treated at our institution from 2018 to 2024 who were determined to have a postoperative stricture amenable to dilation after their primary PSARP or pull-through operation. The diagnosis groups were analyzed separately. All patients underwent Hagar or balloon dilation per standard protocol. After dilation, 40 milligrams of Kenalog was then injected directly into the stricture, with taking care to avoid the perineal body, particularly in patients with ARM. All patients then underwent an EUA 1 to 3 months postoperatively to evaluate their clinical response. A total of 50 patients, 30 with ARM and 20 with Hirschsprung disease, were included in our study. The most common ARM subtypes were rectourethral fistula and cloaca. The majority of patients in both groups were males, and about half of patients in each group presented with difficulty stooling, whereas the other half were asymptomatic. Patients in both groups were of a similar age at the time of their primary operation. Most patients then had at least one intervention for stricture before their first steroid injection. For patients with ARM, their first injection was performed at a median age of around 4.5 years, about 3 months on average after their most recent intervention for stricture. Patients with Hirschsprung's disease underwent their first injection at around 1 1/3 years of age, around 1 month after their most recent intervention for stricture. Both groups had a follow-up of over 1 year in our study. For the ARM group, 21 patients were successfully treated with dilation and injection alone, and 9 patients ultimately required a surgery after their injection to achieve stricture resolution. Of the injection group, about 2/3 of the patients achieved stricture resolution with just 1 injection, whereas the other third required 2 or more. When we compared the group who required surgery to those who achieved stricture resolution with dilation with injections alone, we found that there were no statistically significant clinical differences, including a history of prior dilation for stricture, prior surgeries for stricture, or other postoperative complications from their prior operations. For the Hirschsprung disease group, 17 patients achieved resolution of their stricture after dilation with injection alone. 2 ultimately required a redo pull-through operation, and 1 is diverted and still undergoing treatment at this time. For the injection group, about half resolved with only 1 injection, whereas the other half required 2 or more. And similar to the ARM group, there were no significant differences in preoperative clinical characteristics between those who ultimately required surgery and those who did not. There were no intraoperative complications from steroid injection in either group. The overall 30-day wound complication rate was about 2.2%, and there were no patients who experienced systemic side effects or complications. Additionally, all patients in both treatment groups who were not diverted were stooling well without obstructive symptoms at the time of their most recent follow-up visit. 3 patients with ARM and 1 with Hirschsprung's remained diverted. Our results demonstrate that stricture dilation with steroid injection was overall safe and effective. There is a low rate of wound complication, no systemic complications. 85% of patients with Hirschsprung disease and 70% of patients with ARM achieve stricture resolution without the need for further surgery. These rates of successful treatment approach that of surgical options, such as the Heineke-Mikulitz anaplasty, which was recently reported at around 85%. Our study is limited by its small sample size, as well as the lack of a control group, which does limit the conclusions that can be drawn regarding the comparison between dilations with versus without steroid injections. Additionally, patients were given the steroid injections based on provider discretion without randomization, so it is likely that there are more complex patients are represented in our cohort. In conclusion, intralesional steroid injection with dilation of postoperative stricture is a safe, minimally invasive approach to stricture management for patients with ARM and Hirschsprung disease, which may help to decrease the need for reoperation for patients with persistent strictures. Thank you again for the opportunity to present. I'm happy to take any questions.
Thank you for your presentation. I just wonder if your high number of strictures that required at least 2 more anesthesia, if they are a result of lack of postoperative dilations.
I don't know that that's something that I can comment on based on the data that we've looked at in this study. I think that that's part of our institution's practice is that we do not do the postoperative dilations, and so we kind of offer each patient the opportunity to declare themselves, and then if someone is presenting with an issue with their with stooling or obstructive symptoms, then we prefer to take them to the operating room to do an EUA to assess kind of the anatomy and determine whether or not a patient needs stricture, or I'm sorry, needs a dilation.
Great presentation. Thanks for sharing. Have you thought about, because I think I want to try this, but I want to know, and you said this in your limitations, what happens if I just do dilations and not do, so did you go retrospectively, could you go back before 2018 and look at what you were doing before and use that as a control to compare dilations versus dilations with plus steroid injection?
We did discuss the option of doing that in terms of this study, but felt that that wasn't a statistically valid approach based on conversations with our analytical team. However, based on our kind of anecdotal experience with our historical cohort compared to the results that we've seen now, we've made the move from only doing dilations with Kenalog injections and avoiding dilations without injection altogether, particularly since we saw the data from this study and how high the rate of single injection resolution was.
Great presentation. I was curious, did you look at like how severe the stricture was? So if you're trying to get to a 14 Hagar and you're starting at an 8 versus a 12, any sense of which patients can successfully do this?
Yeah, I think that's a great question. So both patient groups did have an average change in their Hagar of size of 4. So I think ultimately it does come down to kind of a patient-by-patient decision in terms of a very thick or robust stricture. You may look at and say this may need an HM anaplasty rather than a dilation with injection, but we have found that when we've been using the dilations with the Kenalog injections as a first line, we've been able to avoid even needing to go to HMA even for those kind of moderate sized strictures. But of course, a large or long stricture, I think would be better served probably by a surgical intervention or redo operation.
There's some literature to suggest that the use of mitomycin is more effective than Kenalog for esophageal strictures. Do you have any knowledge of people trying to use this for these low anastomotic strictures in the rectum or anus?
I do know that mitomycin C has also been used in this context as well. In our practice's experience, it was not as effective as the Kenalog, so we had previously used that, and we did look at the outcomes for those patients in our cohort, but it obviously wasn't something that we presented today. But we actually found that most patients that had the mitomycin went on to need further dilations with injections and ended up having resolution with Kenalog. So again, that's anecdotal. We haven't done the actual analysis to say that, but yeah.
Thank you.
Thanks, Dr.
Thank you.
Good job. I'd like to invite Dr. Ahmad from Children's Hospital Orange County to the stage, and we're going to talk about timing of colectomy and surgical outcomes in pediatric patients with ulcerative colitis.
All right.
I'll be presenting on behalf of Dr. Flyer. Thank you for the opportunity to present. I'm Kira Ahmad. So we wanted to look at pediatric ulcerative colitis. We think that literature has shown that it has high incidence of pancolitis at presentation. They are more likely to be steroid dependent, and then it's in general what we've heard already from Dr. Ulrich too, it's a more aggressive disease course. So we wanted to evaluate the impact of timing of pediatric total abdominal colectomy from the time of diagnosis to the time of colectomy in patients with ulcerative colitis. We specifically wanted to look at post-op outcomes, long-term clinical outcomes, as well as healthcare utilization and cost. We hypothesized that the patients who were undergoing total abdominal colectomy less than 2 years from their diagnoses had potentially reduced post-op complications, decreased length of stay, and lower healthcare costs when compared to delayed, and we defined delayed as greater than 2 years from their time of diagnosis. We looked at the FIS database over 10 years from 2013 to 2023 for a total of 1098 patients. So initially I wanted to divide it between less than 2 years and greater than 2 years, but what we found is like there were a significant number of patients that were in this other groups, like group A, that had less than, that underwent surgery less than 1 month post-diagnoses, and I didn't really want to lump them in the less than 2 year cohort because I felt this was a different disease pathology potentially. So 4 groupings were done. Group A had less than 1 month post-diagnosis patients. We think these were like the emergent resections. 1 to 6 month post-diagnosis, which were likely urgent or failure to response, and then early, which was 6 to 24 months, and then late, which were greater than 2 years or 24 months post-diagnosis. For patients in group A and B, so I'll kind of talk about A and B together and then C and D. So patients in group A and B, they had similar age of diagnosis, about 14 years old. When looking at group C and D, patients in group D were diagnosed at an earlier age. For age of years at colectomy, it was pretty similar between group A and B, and then a little bit older population in group C and D. Pretty even gender distribution, and then most of the patients who underwent, a colectomy within a month had a commercial insurance. When looking at groups A and B together, what we found is they were more likely to have severe UC and higher mortality risk compared to patients in group C and D. Group C was had a higher severity, UC severity score compared to group D, but they had similar mortality risk between group C and D. The type of diagnoses most likely were inpatient in patients less than a month and then 1 to 6 months. But then as you can see, there's a variable of diagnoses. I don't know if you can see my arrow or not, doesn't look like it. But sorry, none of these are working. So there we go. In terms of biologics and steroids, group A, as we can probably assume, they didn't have enough time to be on biologic treatments, but most of the patients group B onward were on biologics and steroids. When looking at healthcare cost utilization, we looked at number of encounters that these patients had in the FIS database prior to their colectomy and after their diagnosis of UC. And we found that group C and D were pretty similar across the board. They had higher number of encounters compared to group A and B. The length of stay was highest in group B, but it was pretty similar in group C and D. And then the cost of colectomy was highest in group B, but pretty similar in group C and D. The type of colectomy was inpatient for most. I'm not sure who these 5 surgeons are that are doing colectomy and sending them home, but they're brave. We then looked at the surgical outcomes and complications. So patients in, I'll focus on group C and D here. They had very similar return to OR within 30 days, and the rest of the complications were pretty same when we looked at the anastomosis-related complications, stoma-related complications, bleeding, infections, and line-associated complications. They were essentially the same between the two. We then looked at all comers, all patients with UC who underwent total abdominal colectomy, and looked at the factors that were associated with earlier colectomies, meaning less than 24 months. And all of these factors were significant: age, severity, mortality risk. Found Hispanic and African Americans were more likely to. Medicaid insurance, males if they use steroids or biologics. So in conclusion, when looking at these two groups, the very early colectomy and groups A and B, they who underwent total abdominal colectomy for UC, they had increased disease severity, longer length of stay, and then greater healthcare cost utilization and then subsequent costs. But there really wasn't any difference when we looked at the patients who underwent colectomy between 6 to 24 months after their diagnosis versus the ones that underwent colectomy more than 2 years. So it really can be tailored to patients and families, and we can make a decision together. Thank you, and I'll be happy to take any questions.
Hey, here, great presentation and great data to share. I just want to make sure I'm clear. Did I see that there was a mortality risk of 9 to 10% on that graph or chart?
No,
Is
thank you
that-
for pointing that out and clarifying. This is actually the mortality risk based on patient profile that the FIS generates. So it's an
No,
internal.
further back, I think, on further back on.
Yeah, so
the-
this is their mortality risk. So this is a risk generating calculator that FIS comes up with. They look at their entire patient profile and they say, based on this, and this is what your mortality risk is as a patient in the FIS database, based on their comorbidities or their severe, what medications
Those
they're
are
on.
scary numbers.
Yes, these are not real numbers. Well, real in a way that it's like a FIS calculator, but it's not necessarily what their mortality rate was.
Yeah, and my second question is, I agree, trying to tease out how to combine group A and B, because likely these patients are all getting started on induction therapy, which takes somewhere, depending on which of the 24 drugs that are now out there,
right,
somewhere between 4 and 12 weeks to just finish induction. That's probably all going to be calculated. And then the GI colleague is going to say, all right, we failed medical therapy, and then go, unless they're really sick, like you
Right.
said, and they're bleeding and getting a few units of blood, and then they pull the triggers.
Right.
So thank you. Great job.
Thank you.
We have time for one more question.
I find the FIS database really hard to work with and confusing. And so I was wondering, how did you figure out diagnosis time in FIS? Because you can tell when they enter a hospital system, but if they're outside referred, they get a new ID. And it's not so clear to me how you know start of disease from that data set.
That's a really good question, and that's the one that we kind of struggle with a lot too. And at the end of the day, we determined that the first encounter that the UC diagnosis was entered was considered their time of diagnosis. There was really no other way around it, unfortunately.
Sorry, no more questions. We have to move on. I apologize.
Thanks.
Next, we have Dr. Roberts from Cohen Children's, who will be presenting colorectal closure bundles may be associated with longer operative times without improved outcomes.
Good afternoon. Thank you. My name is Bailey. I will be presenting on colorectal closure bundles. We have no disclosures. So intraoperative closure bundles are used in adult surgery to decrease surgical site infection rates, and they're well studied in the adult colorectal surgery. The use of these elements varies widely across centers, but it includes things such as new sterile trays, changing of sterile gowns, changing sterile gloves, and sometimes addition of a wound vacuum device. While there is studies that show that protocolized perioperative care in pediatrics is useful for reducing complications and infections, there's very little known on the effects of the intraoperative bundle use and what these specific elements are in pediatric surgery. We conducted a multi-institutional retrospective review. The review was studying bowel preparation with the Eastern Pediatric Surgical Network Consortium, and we collected data on intraoperative closure bundle use. The patients were children under 2 years old undergoing colostomy reversals with diagnoses of Hirschsprung's disease and anorectal malformation. The aim of this study was to determine if use of intraoperative closure bundles is associated with reduction in surgical site infection complications. There were a total of 611 patients in this study, of which over 400 patients had known data about use of closure bundles. Of those, 109 patients had a closure bundle element used, and 325 had no closure bundle elements used. These elements included new sterile trays, new sterile gloves, new sterile gowns, and incisional wound vacuum devices. Some patients, there were multiple bundles used in the same patient. Most commonly, changing of sterile trays and changing of sterile gloves was used. There was a wide variation amongst the 20 institutions of their use of closure bundles. Importantly, even within the institutions, there was variation of the patients from those institutions, implying that there was different practices by different patients and not necessarily a widespread adoptance of one type of closure bundle. Firstly, we found there were no differences in the demographics between the closure bundle group and the no closure bundle group. The most common diagnosis in this cohort was congenital anorectal malformation, and more commonly with fistula than without fistula. And a small cohort, about 20% of them, had Hirschsprung's disease. We did find that patients that had closure bundle elements used during their case also had the use of preoperative bowel prep and an intraoperative rectal washout, which are also commonly found within bundles. With about 60% of the closure bundle patients having a preoperative bowel prep compared to about 35% without the closure bundle. And then just over half had a rectal washout, whereas 20% without any closure bundle elements had a rectal washout. We found that there were no differences in any major complication, including surgical site infections, deep site infections, anastomotic leak, and wound dehiscence between the two groups. There was a difference in anastomotic leak rate, with the closure bundle group having a slightly higher amount of leaks, but this is not very clinically significant as it is a difference of only one patient. There was no differences in the length of stay total or the post-op length of stay between the two groups. However, we did find that there was a significant difference in the length of the operation, with a difference of about 40 minutes between the two groups. So the closure bundle groups had about a 40-minute longer operation compared to the no closure bundles. So in conclusion, the closure bundles may not be associated with improved outcomes in ostomy reversals in children, and they may be associated with longer operative times that can lead to more resource use and waste. Standardization is necessary for us to understand the improvement of these outcomes and what elements of our protocols we should be including to reduce waste while also improving outcomes. This study is limited as the data was collected retrospectively in a small subcollection of patients of just the anorectal malformations and young children. And it did rely on use of any closure bundle element and may not actually capture the benefit of combining all of these elements. I'd like to thank the Eastern Pediatric Surgical Network and my mentors at Cohen Children's, and I'm happy to take any questions.
Congratulations. I think in medicine, we usually make changes, but we don't reverse them when we see that they are not effective. So congratulations for doing that. I think in an ostomy reversal, it's understandable. The skin is already contaminated, so there's no way to protect the skin from a colonic bundle. So it makes no sense for me to do it. So congratulations. My question is 40 minutes just to change the gloves and the tray? How do you explain that?
I agree. I think some of this can be explained by the fact that most of these institutions, based on the variation, were not following we always use a bundle, we always do not. And so perhaps those patients had a slightly more complicated operation that would have necessitated those changes, and that could contribute to the longer operative time, but we don't have a way to really suss that out with the information we have.
Well, I think that was a very interesting study. I think it could also be interpreted that it's very hard to implement a bundle. When you start out on a bundle, often you don't necessarily make improvements, and sometimes you get worse. Like you start reporting and reading and checking your data, and you realize that you're catching things that you missed previously. And the power of bundles really is in the iterative PDSA cycle and the quality improvement type methodology as opposed to trial methodology. And I think that it would be really interesting, in your manuscript to look and pick apart the details of what things were and weren't implemented and why there was such variability between different things, because I think that bundles are very, very helpful. And the thing that makes them helpful is the iterative improvement that we're attempting to do.
Absolutely. Thank you.
Great job, Dr. Roberts.
Thank you.
Our last abstract for today, Dr. Rook is coming to the stage to talk about evaluating the modern epidemiology of meconium-related obstruction. This is a retrospective multi-institutional consortium study. He's coming to us from UCLA Mattel Children's Hospital on behalf of the University of California Fetal Consortium.
Thank you. A few years ago, we treated several preterm infants for meconium-related obstructions at our institution, all of whom required surgery. We were surprised to find that none of them had cystic fibrosis, which most textbooks report to be present in about 80% of these cases. When we turned to existing literature, we found only a few case series describing infants like those we had treated. To determine how to best care for these infants, we began by conducting an institutional series. We found that of 18 infants with meconium-related obstruction, only one had cystic fibrosis. We also used this series to validate a strategy to identify meconium-related obstructions using ICD-10 codes. We then applied this identification strategy to national claims data, where we confirmed that most meconium-related obstructions occurred in preterm infants without cystic fibrosis. Furthermore, over a 5-year period, these obstructions were associated with 22,000 excess hospital days and about $70 million in healthcare costs nationally. With this foundational knowledge, we turned our attention to the following research questions. For obstructed infants, what are the risk factors for requiring surgical intervention, and how are these patients being managed across institutions? To answer this, we conducted a mixed methods multi-institutional study comprised of a retrospective cohort of infants with meconium-related obstruction and a survey of neonatologists and pediatric surgeons. For the retrospective cohort, we included infants treated for meconium-related obstruction at 7 children's hospitals participating in the University of California Fetal Consortium over a 5-year period. We assessed the primary risk factors of prematurity, cystic fibrosis, and Hirschsprung's disease. We primarily assessed the outcome of need for surgery. We assessed additional maternal, prenatal, sociodemographic, and clinical covariates that could plausibly affect our outcome. We used bivariate statistical tests to compare meconium-related obstruction by type. For the survey, we distributed an online survey in February of 2025 to neonatologists and pediatric surgeons at the same 7 institutions assessing prevention and management strategies. For our cohort, we identified 105 cases of meconium-related obstruction. The graph above depicts the presence of concomitant cystic fibrosis or Hirschsprung's disease by degree of prematurity. Most obstructions occurred in the absence of either condition, as depicted by the gray portion of each bar. This was particularly notable among infants born less than 34 weeks. Separating these obstructions by type, we can see that most patients required at least a contrast enema to address their obstruction. Rates of surgical intervention were highest for infants with cystic fibrosis, of whom 4 of 6 required abdominal exploration, followed by meconium-related obstruction of prematurity, of whom 21 of 54, or 39%, required surgery. Of note, this only includes surgeries for an indication of meconium-related obstruction and thus does not include infants who underwent planned operations for Hirschsprung disease following a pathologic diagnosis on suction rectal biopsy. Of the 27 patients who required surgery, 24 were preterm. Over half of infants born at 32 weeks or less required an abdominal operation. On regression analysis, each 1-week decrease in gestational age was associated with a 23% increase in the odds of requiring surgery. The most common indication for surgery was perforation. 21 patients underwent exploratory laparotomy at their index operation, while 6 underwent drain placement, 5 of whom later required abdominal exploration. For our survey, we had 42 responses with a final response rate of 24%. There was significant variation in preferences regarding contrast enema, rectal irrigation, and timing of interventions. Overall, only 3 of 42 providers reported the presence of any institutional pathway for treating an infant with a meconium-related obstruction. These providers represented 2 of our 7 institutions. In summary, in this multi-institutional study, we confirmed that cystic fibrosis is a rare cause of meconium-related obstruction. Increasing prematurity was the primary risk factor for developing meconium-related obstruction, as well as the need for surgery. Lastly, there was no consensus regarding effective treatment strategies across institutions. Now that we have begun to define this disease, our future work will seek to improve management strategies. With these clinical and survey data, we have already produced a preliminary prevention and treatment algorithm for meconium-related obstruction of prematurity. The goals of this algorithm are to prevent meconium-related obstructions among high-risk infants and to improve non-operative management strategies such that surgical intervention can be avoided for these fragile neonates. Our next steps will be to build consensus prior to implementing this protocol at our UCFC sites. Thank you to my mentors, particularly Dr. De Agarte and the UCFC for making this research possible. Please scan the QR code if you'd like to review the algorithm in detail. We'd appreciate all feedback. Thank you.
Hey, Andrew Zigman, Portland, Oregon. Thanks for bringing that interesting information to us. You had a very wide range of ages. You had the term over 37 weeks, and you had infants who were more than 10 weeks younger than that. Were you able to, in your review, determine any difference in the cause or the nature of the obstruction between those really older term babies and the little preemies?
Yeah, absolutely. So that gets to this distribution of cystic fibrosis, Hirschsprung's disease, et cetera. So amongst the term infants who are much less likely to develop this sporadic meconium-related obstruction, your incidence of cystic fibrosis or Hirschsprung's disease is much higher. But as these infants get increasingly preterm, these fairly rare diseases for which the incidence doesn't change according to the level of prematurity get completely overshadowed by this preemie bowel that's producing these meconium-related obstructions of prematurity. So that's where we're finding very few cases of cystic fibrosis and Hirschsprung's disease, just because it's so much less likely than the other etiology.
That's a good observation. And something else that we've noticed also is getting these lactobezolars. We're seeing them more so in the young kids who are getting fortified, and they're getting obstructed, they're perforating. And were you able to suss out any of those sort of lactobezoar type obstructions in your cohorts?
So that's really interesting. We actually, in none of our, in my review of the data across our 7 sites, I don't remember that coming up at all. It's something we can discuss, but to my knowledge, it wasn't described in our cohort.
Okay, thanks for bringing it up.
Really great job, Dr. Rook, and really agree, like these premature kids who are especially getting fed younger and younger, do they have inspissated anaral feeds causing obstruction versus was it meconium? So look forward to reviewing your abstract, your protocol there. So thanks very much.
Thank you.
We're going to now have our first break of the afternoon, so please stop by and thank all of our vendors because they support the conference. We're going to start our scientific session 5 through 8 at 4 o'clock. And following that, you'll have some free time and then see you at the welcome reception at 5 o'clock. Thanks, everybody.